As with any other history of other systems, the cardiovascular history is extraordinarily important. So as we're asking questions, be sure to ask about family history because primary relative with heart disease is a primary risk factor. Males have a greater risk than females until menopause. People under the age of 25, Native Americans, are 2 times higher risk. Black males are 2 times as likely to die from stroke. With hypertension, as you already know, it causes enlargement of the heart, which leads to ineffective pumping, decreased cardiac output, and congestive heart failure. More Black and Hispanic men smoke, but Caucasian men are heavier smokers. So be sure to get a history on smoking. And then people that are in excess of 20% of the standard weight for their age and height are at higher risk. Increased lipids, total cholesterol greater than 200, LDL greater than 100, and HDL less than 40 are all high risk factors. And diabetes, of course, is the leading cause of death in the United States, number 7th leading cause of death, and it increases the risk of cardiovascular disease by 30%. Also, physical inactivity, sedentary lifestyle causing obesity and deconditioning are high risk factors, as is stress. When completing the history, be sure to ask about chest pain. Be very specific about questions using your old carts. Angina is caused by lack of oxygenation to the heart muscle. Also ask about difficulty breathing, orthopnea. Ask how many pillows do they sleep on at night. Sometimes people will say they sleep in their recliner. That can be indicative of pulmonary or cardiovascular problems. Ask about a cough, increasing fatigue, change in color, whether it's cyanosis or pallor, edema, nocturia, are they getting up frequently at night to urinate, and have they noticed palpitations? These can all indicate heart failure or heart damage. PND, or paroxysmal nocturnal dyspnea, also occurs with heart failure. When the patient lies down, it increases the volume of blood in the inner thoracic cavity, and a weakened heart can't accommodate for this increased workload. So classically, the patient wakes up after about 2 hours of sleep, sits up, opens a window, or takes a deep breath, feeling the need for more fresh air. Actually, I've had patients that have said, I don't have any shortness of breath. I just wake up at night, and once I sit up, I'm fine, so I go back to sleep. But it can recur frequently throughout the night. Myocardial ischemic pain, also called the choking heart, is often precipitated by exertion. It's been described as squeezing, pressing, heavy, or constricting, and it's often hard to distinguish from pain from other sources. An abnormal EKG during the episode will help confirm the cardiac origin, but a normal EKG does not rule it out. Pericardial chest pain is caused by inflammation involving the parietal pericardium. It's described as burning, stabbing, or cutting, and it's exacerbated by coughing, swallowing, deep breathing, and lying down. Leaning forward or remaining motionless often will relieve that type of pain. Atypical chest pain tends to be stabbing or burning, and its position can change from one episode to another. It varies in severity and can last for seconds to hours to days. It's usually unrelated to physical activity, and its relationship to cardiac pathology is controversial. On this side, review the gender differences in chest pain. Female heart attack symptoms can look very different from those of men. In fact, according to studies of women and early heart attack signs, women have more unrecognized heart attacks than men and are more likely to be mistakenly diagnosed and discharged from emergency departments. Although women can have chest tightness as a symptom of a heart attack, it's also important for women to recognize that many women don't have chest pain. A study published in the medical journal Circulation, Journal of the American Heart Association, cited that during a heart attack, 43% of the 515 women studied had no acute chest pain, which is a hallmark symptom in men. Chest-related heart attack signs often appear in men, and many women get them too, such as pressure, fullness, or a squeezing pain in the center of the chest, which may spread to the neck, shoulder, or jaw. Also, chest discomfort with lightheadedness, fainting, sweating, nausea, or shortness of breath. Women commonly have symptoms of shortness of breath, unexplained fatigue, or pressure in the lower chest, so they can easily be mistaken as a stomach ailment. Backward failure of the left ventricle causes congestion of the pulmonary vasculature, and so the symptoms are predominantly respiratory in nature. The patient will have dyspnea on exertion, and in severe cases, dyspnea at rest. Increasing orthopnea also occurs. It is often measured in the number of pillows required to lie comfortably, and in severe cases, the patient may resort to sleeping while sitting up. Pulmonary causes would be stiffening of the lungs, alveolar edema of congestive heart failure, fibrotic changes, loss of lung volume, COPD, and lung tumors. Another symptom of heart failure is paroxysmal nocturnal dyspnea, or sudden nighttime attack of severe breathlessness, usually lasting several hours after going to sleep. Easy fatigability and exercise intolerance are also common complaints related to respiratory compromise. Cardiac asthma or wheezing may also occur. Compromise of the left ventricle forward function may result in other symptoms of poor systemic circulation, such as dizziness, confusion, and cool extremities at rest. Weakness or fatigue result from insufficient cardiac output. It may first be noticed with exertion, but as the disease progresses, it may be noticed throughout the day. It's unrelieved by rest or sleep, and patients often experience heaviness in their limbs. Lightheadedness, presyncope, and syncope occur when blood supply to the reticular activating system in the brainstem is interrupted or reduced. It's caused by insufficient cardiac output from either an arrhythmia or organic heart disease. Causes may be aortic stenosis, hypertrophic cardiac myopathy, and non-cardiac causes such as postural hypotension and vasovagal syncope. Exertional syncope can occur with aortic stenosis or hypertrophic cardiac myopathy. Severe bradycardia or tachycardia may also cause syncope. When getting your history of present illness for the chief complaint, be sure to get the mode of onset, whether it was gradual or sudden, how long it lasted, if the patient has had similar episodes in the past, and if they have, how is this one different? Also, find out what they were doing as the pain started, and if there is radiation. Ask them to point to where the pain is. Also, ask how the character of the pain has changed over time, and what makes it worse, such as deep breathing, coughing, movement of the neck, arm, or chest, changing position, exertion, emotional upset, if it's harder when they swallow, or if it came on with sexual intercourse. Also ask about alleviating factors, such as does it go away with food or antacids or H2 blockers, PPIs, nitroglycerin, analgesics, or does it go away with rest or position change or massage of the painful area? So how quickly was the pain relieved? Was it a few minutes, few seconds, few hours? Also ask about past treatment. When, where, what, and by whom. Past studies that they've had, if the diagnosis was made, and what treatment was given, and what the outcome was. Also ask about the effect on daily life. And don't forget about asking about associated symptoms. Do they have faintness or syncope, fever, shaking, chills, weight change, sweating, numbness of hands, or numbness around the mouth? Other associated symptoms might be shortness of breath, sweating, dizziness, faintness, being cold or clammy, bluish lips, pallor, swelling or edema, palpitations, and then don't forget to ask about treatments tried, beta blockers, ACE inhibitors, NSAIDs, digoxin, diuretics, etc. When reviewing the past medical history, ask about any cardiovascular diagnoses or congenital heart disease. Ask about history of MI, heart murmurs, chest injury, hypertension, angina. Ask what their last lipid panel was if they know, if they've had an EKG or echocardiogram, a history of elevated lipids. Ask if they've had lung disease, asthma, diabetes, history of phlebitis, or anxiety or depression. Also ask about history of medication use, whether they're taking things now or have in the past. Ask them why they were taking the medication, what the dosage was, and the frequency. As you're getting the personal and social history, make note of what their dietary intake is typically like, if their weight has remained unchanged, or if they've noticed changes in weight gain especially. Ask about alcohol use, whether they smoke or use any other type of tobacco, what their activity pattern is, and stress levels. Cardiovascular disease, especially in a first-degree relative of men under the age of 55 and women under the age of 60, is an extremely high risk factor, as is premature death under the age of 50. This slide and the following 3 slides all are questions that you should include in your review of systems of the cardiovascular system. In order to determine the best course of therapy, practitioners often assess the stage of heart failure according to the New York Heart Association functional classification system. This system relates symptoms to everyday activities and the patient's quality of life. Class 1 is mild, where there are no limitations of physical activity. Ordinary physical activity does not cause undue fatigue, palpitation, or dyspnea. Class 2 is mild, where slight limitation of physical activity. Patient is comfortable at rest, but ordinary physical activity results in fatigue, palpitation, or dyspnea. Class 3 is moderate. Marked limitation of physical activity. The patient is comfortable at rest, but less than ordinary activity causes fatigue, palpitation, or dyspnea. And Class 4 is severe, where the person is unable to carry out any physical activity without discomfort. Symptoms of cardiac insufficiency at rest, if any activity is undertaken, and discomfort is increased.